This
never
conference
hear
will now be
anything
recorded.
discussed about sex. Should I start over, I guess?
Yes, go ahead.
So yeah, sorry about that. But at any rate, sex is the elephant in the room. I've been to many of these support group meetings, and issues about sexuality and intimacy never come up. You know, it is the elephant in the room. And, you know, just kind of ironically, maintaining potency and other sexual concerns are an underlying issue with choosing active surveillance, and they certainly are issues for men who undergo radical prostatectomy. Any rate, so these issues are intertwined, but we're going to talk tonight initially about sex and the man on active surveillance, and we're lucky to have as our speaker an international expert on intimacy, sexuality, and cancer, and specifically prostate cancer. And our speaker is Dr. Katz, certified sexuality counselor and clinical nurse specialist at CancerCare Manitoba in Winnipeg, Canada. Dr. Katz is the immediate past president of the Oncology Nursing Forum, Oncology Nursing Society. She was inducted into the American Academy of Nursing in 2014 and is the author of 13 books for healthcare providers and healthcare consumers on the topics of illness and sexuality, as well as cancer survivorship. Her latest book is the second edition of Women, Cancer, Sex. She's also author of Prostate Cancer and the Man You Love. So I'm gonna post information about that book for the group. And now I just turn it over to Ann.
Okay, I somehow got muted. So anyway, let's start again. So I'm happy to be here on this auspicious evening, and hopefully we'll be able to distract you all for a little while over some of the goings on today. So, you know, what's the big deal about sex, period, and Howard talked about the elephant in the room, and I like to think of myself perhaps as an elephant tamer, because for me this is, you know, I recognize that this is such an important issue for men, and in fact, just today I got I had a lengthy text conversation. We eventually went to the telephone because sometimes that's the best way to do it, with a gentleman, young guy, 65 years old, just a really nervous person. He had low risk prostate cancer, low volume prostate cancer, but he's just someone who's really, really quite neurotic. He just, you know, could not even think about living with prostate cancer that was untreated. I really tried to support him in choosing active surveillance because of his disease status, and he had, you know, he was not interested. Had surgery. He's now 3 years post-surgery with a whole host of sexual problems, profound erectile dysfunction, and Peyronie's disease, which is about 10% of men who have a radical prostatectomy develop Peyronie's disease, or curvature of the penis. And this man is just really, 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 really unhappy. He feels diminished. You know, sex was a great pleasure for him, and my heart really aches for him. So for those of you who are living on active surveillance, flourishing on active surveillance, really I applaud, which I think for a lot of men really takes a lot of courage, and you'll hear in a little bit why I think that is so. Joe, next slide, please. There we go. So, you know, just to put this in context, active surveillance is something that is active. It is not the same as watchful waiting, which is something that was practiced and perhaps is still practiced in some jurisdictions, where basically we don't treat the man and we tell him to go away and come back when he is symptomatic, sometimes with metastatic disease. So really, active surveillance, as most of you know, is deferred or delayed treatment for prostate cancer. And it really is an active process with ongoing monitoring, PSA, and perhaps repeated biopsies. And this, can pose some problems, which I'll talk about in a little while. But really, at the heart of this is avoiding the side effects from other treatments. And this really should be done in a context of trust. And really not moving away from this monitoring. So it really is active. Next slide, Joe, please. So, we know that men do really well on active surveillance. They have high quality of life because not much has changed. And in those who do choose to move to active treatment, not necessarily because their disease has progressed to the point that they need active treatment, but sometimes because, they just get tired of the repeated biopsies and PSA screening, or perhaps their family members pressure them, Dad, come on, just, get over it. Are you crazy? Why are you doing this? Our adult children want us to live forever. So we know that those who do move to treatment, about a quarter of them really experience treatment regret. And that's can really have a large psychological impact. Next slide. So, one of the things that's really important in everything that we do, but certainly communication with physicians, and I'm going to talk in a little while about communication with your partner. A lot of this depends on what the physician recommends. And men have trust in their primary care provider, their urologist, family physician, nurse practitioner. So if the physician recommends active surveillance, men are more likely to go on it. However, in a fairly large recent study, they found that there is rarely a discussion about sexuality, sex, and you'll notice I'm not talking about intimacy. So I have a couple of things that get me on my soapbox. And pardon me, Howard, I know you talked about intimacy. Often intimacy is used as a euphemism because people are afraid to actually say sex or sexuality or sexual intercourse. So they talk about intimacy. I see this all the time in my practice. Couples, individuals come to me and they say, I'm having a problem with intimacy. And I say, well, is the problem a lack of emotional connection to your partner? Oh, no, it's not that at all. He or she's been absolutely amazing. We're closer than we've ever been. The problem is in our sex life. So I really try to distinguish between those two. So Howard, my apologies, but I just really want to explain sort of my standpoint on this. Another study, even more recent from 2018, showed that men who do choose to have treatment initially are often unaware of the sexual changes that will occur. I don't say may, they will occur. And even more, don't understand or aren't warned about urinary complications. And that's primarily urinary incontinence after radical prostatectomy. So, there's, I think, a certain amount of denial. There's a certain amount of magical thinking. It's not going to happen to me. It'll happen to everybody else, but it won't happen to me. And I see this a lot in my practice. But men really want to preserve sexual function, and that is important to them. It's important to quality of life. It's fun. It's a comfort. It's part of, it's the way we connect with our partner. So it's something that is really important. And if this is not discussed in terms of, if you have radiation therapy, if you have a radical prostatectomy, you're absolutely going to see changes in sexual functioning. And it's not just about erectile dysfunction. There are other sexual changes, including dry ejaculation, the risk of Peyronie's disease, urinary leakage with arousal or orgasm, genital shrinkage. I could go on, and I'd probably lose a whole lot of attendance because some of them are really kind of scary. Next slide, please. So what are the side effects of active surveillance? Is this a choice that has no side effects. Anything that you do has the potential for side effects, and certainly there are side effects from being on active surveillance. Next slide, please. So, anxiety is one of them, and one of my roles as clinical nurse specialist at the Prostate Center here in Winnipeg is to help men make a treatment decision. So I meet with men fairly soon after they're diagnosed, and based on their pathology, the pathology from the biopsy, we talk through the treatments that they are eligible for. And when I encounter a man who is extremely anxious about everything, this is a man whose blood pressure goes up, a week before he's due to have a PSA test. It only goes down if his PSA is okay. So somebody who is really anxious, perhaps active surveillance is not the best choice for them. Certainly, there's a lot of uncertainty involved in active surveillance. How long can you be on active surveillance? What is going on in my body? Is the cancer growing? Perhaps wanting to have MRIs and other imaging studies, many of which have certain risks attached to them. I don't particularly think that someone who is struggling with this uncertainty necessarily should remain on active surveillance, or really does need the support to work through that uncertainty and kind of put it in its place. Certainly, if you don't have surgery or radiation, you avoid treatment regret. For some men, and I'm going to explain this in a moment, you are able to retain your sexual function and certainly intact bladder and bowel function. For a man who has a large prostate and he's getting up, 7 times a night to go to the bathroom, his sleep is going to be impaired. He's probably going to irritate his partner because he's getting up constantly. So, perhaps for those men, treating the large prostate is perhaps a good idea, even if you don't go for a radical prostatectomy or radiation. But certainly we see far less urinary complications on active surveillance, and certainly no changes in bowel function. I want to talk a little bit about anxiety, because I think this is really important because it has sexual consequences. Next slide, Joe, please. So we know that anxiety carries its own burden of problems. So we see men experience loss of desire or loss of libido because they're so anxious. We see men have erectile problems, either failure to achieve an erection, rapid or what used to be called premature ejaculation, inability to have an orgasm, we call that anorgasmia. All of these are related or can be related to anxiety and really do cause diminished sexual function. We also know that for men on active surveillance, there is some evidence, and it's really early studies now, and it's a little bit controversial, but there are some studies that show that repeated biopsies may contribute to erectile dysfunction. And in the one study that showed this, this was irrespective of age. And I'm going to talk a little bit more about age in a little while. So there you have a investigation that would be done in some instances every year. The recommendations are after repeat biopsy, after diagnosis at a year, you go to biopsies every 2 years, that these repeated biopsies can cause problems themselves. We also have to think about the response of the partner. And often partners themselves are extremely anxious about the man being on active surveillance. So the man may be able to, control his anxiety, control his uncertainty, but the partner is not able to do that. And we also know that in men who are having certainly sexual difficulties, that partners find it really, really hard to deal with the changes. And it's not necessarily about their own sexuality or their own sexual functioning, but partners tend to assume in some instances, if there's no communication, or see changes in the man who perhaps is feeling less masculine, has poorer sexual self-image, that partners find it really, really difficult to deal with this. Next slide. Please remember that the brain is the biggest sex organ, and the brain can get in the way of pretty much everything that is happening sexually. It can get in the way of being able to both achieve and maintain erections. It can certainly get in the way of how you see yourself as a man. And obviously the same thing applies to women who are dealing with these kinds of changes. So we really can't, even though I think often men try to assign blame on other things, often it's the brain that is getting in the way. Next slide, please. You also have to remember that as you move through hopefully years of active surveillance, delayed or deferred treatment, sexual changes are natural and normal because age is not a friend to the penis. This is, for those of you who don't know, the emoji for penis on Twitter and Facebook is the eggplant for somewhat obvious reasons. So, as a man ages, his testosterone levels go down. There are changes in the teeny tiny arteries that supply blood to the penis. And that is why, for many people, sexual functioning diminishes over the years. And it's interesting because since the advent of drugs like Viagra, Cialis, and Levitra, we've seen an absolute radical change in the way we talk about male sexuality. So prior to 1998, if a man complained about decreased erectile capacity, he would be told by his primary care provider, natural, normal, part of aging, live with it. Since Viagra, etc., has come along, the expectation is that men will retain, some form of erectile functioning, and if it's diminished, well, you just take a pill for the rest of their lives. And I think this is really an interesting change in the way that we view male sexuality. We also view male sexuality very much in a mechanical way, an on or off switch, whereas female sexuality is seen as super complex with, buttons and dials and everything that have to be pressed to make things work. And the reality is that men are sexually complex creatures too. You are not necessarily able to have erections with bombs falling around your ears. I often see men who say, ever since I've had the biopsy and I've been diagnosed with prostate cancer, my erections aren't what they used to be. And I'm kind of going, duh, why would there be? You've just had this massive change in your life. Cancer for most people is viewed as a threat to life itself. So why wouldn't you see changes there? Joe, next slide, please. So what is sex? There was a very interesting paper written by, I think she's a sociologist from Australia a number of years ago, who talked about the coital imperative. So I love that term. I think about it a lot. So what is it that makes penetrative intercourse the holy grail? I have some ideas. It works. Many of us have been doing it for, many years. There are certainly advantages beyond procreation. And so often the inability to have penetrative intercourse for men or for women for that matter, really precipitates this big crisis about, I can't have sex. What am I going to do? And the reality is that, there are many different forms of being sexually active. And, the last point there harkens back, I think, to the McCarthy days, where somebody said, you know what pornography is when you see it. You'll recognize pornography when you see it. And So, I really encourage my patients to really think beyond just penetrative sex, and perhaps to think about, what things were like and how exciting, novel, pleasurable life was, way back, where perhaps sexual intercourse was not allowed for a variety of reasons, where all the kissing and canoodling and fooling around, first base, second base, I guess third base is intercourse. I'm not very sports oriented. So, there's a process when sexual changes occur. And part of that is mourning and grieving what was lost. So, I've talked a lot about problems, and I know from my practice that many men who are on active surveillance actually do really well. They preserve sexual functioning despite the changes produced by age, increasing age, and that's one of the reasons why they stick to it. We know that about 30% of men will actually go off active surveillance for a variety of reasons. The choice of the man, perhaps pressure from family members, or progression of disease. But I really encourage patients to at least consider it. And it's always surprising to me how many men actually don't know anything about it, or have a really misguided or misinformed idea of what it is. And I think, part of my role is to help educate. And it's something that I hope you all will do when you, as you will, encounter friends, family members, or perfect strangers in the grocery line who will physically distance, who will tell you their story, and perhaps you can encourage them as long as their pathology allows it. So I want to leave time for questions, because I'm hoping that there'll be a lot of questions. Joe, if you could just go to the next slide. This is my shameless self-promotion. So these are the two of the books that I've written. I actually think that I've written more than 13 books now. I've just finished. So I think the second edition of Woman, Cancer, Sex was number 14, and I'm busy writing another book now. So that'll make it 15, which sounds like a really nice number to stop at. I was going to stop after number 1. So let's open this to questions. I think just before I get there, the reality is that I had a really difficult time finding anything in the medical literature around sexuality and active surveillance. So, I think the truth of the matter is that this is under-researched. I think there is little attention paid to it because this practice hasn't been around for that long. And I think in the years to come, we will perhaps see more. And if any of you are ever offered the opportunity to, be in a qualitative study, a focus group study, please join, because that's how knowledge is generated. So let me open to questions. I'm going to leave this up to the moderators now.
Yeah, Joe, can you turn on the mic? Joe? You won't turn on?
Okay, so there is a question.
You're on, Howard.
Okay, because you keep saying turn on the mic.
I didn't turn everyone on. I just turned on a few people.
Okay.
There's actually a question in the chat, which perhaps I'll start with. So is it safe for men on active surveillance to take L-arginine for sexual function? There's nothing that says you shouldn't, but the question is, does it actually work? And that's always important to me. A lot of these supplements, really the placebo effect is really large. So, it's upwards of 30%. So, if that works for you, absolutely. Perhaps you'd want to consider swallowing an M&M and see if it has the same effect. But, it's certainly, there's nothing to contraindicate that. So here's another question from Michael. Are you aware of any negative sexual impacts of simply having prostate cancer without treatment other than the mental aspects? Generally, no. I think that, you know, certainly if the prostate is growing in size, which happens as men age, you know, for women, we start to everything kind of goes south. But for men, your prostate enlarges. That, you know, perhaps might have some effect because the prostate doesn't just enlarge inward, pressing on the urethra, it'll also enlarge outward. But, you know, I don't think, really don't think that there's an issue. So now there's a private question. I don't know what that means, that it's, I need to reply privately. Okay, I will get to that afterward. I just saw that. Here's another one. The bottom line, with all the possibilities of sexual urinary and other complications that will result, and the fact that active surveillance will end at some point, at what point then in active surveillance does it make sense to move to active treatment? So I think, you know, it's a personal choice. I think some men, frankly, just get tired of biopsies, which are not pleasant. You know, we know that a certain percentage of men are going to land up with sepsis or a systemic infection, often requiring hospitalization for IV antibiotics from a biopsy, because the biopsy needles go through the wall of the rectum. So somewhere between 5 and 10% of men, or sometimes even a little bit higher, will actually get sepsis, necessitating hospital admission, which is really not fun, and you can die from sepsis. So I think men get tired of it. I think sometimes, depending on the practice of the urologist that you are seeing, some urologists have a threshold, a cutoff point, after which they will not do radical prostatectomy. So the urologists that I work with, their cutoff point is 70. They will not offer surgery to a man over the age of 70, no matter how healthy he appears or he says he is. And so sometimes you have a 60, you know, I'll see a 68 or a 69-year-old man who's been on active surveillance for 5, 6, 7 years. You know, everything's looking good, but he's kind of nervous that, you know, he's going to hit that 70 point, and then surgery is off the table. And even though radiation is as effective as surgery in taking care of the cancer, perhaps, you know, he just doesn't want to have radiation. So sometimes, you know, at the age of 68 or 69, he'll kind of, I don't want to use a gun term, but he'll kind of pull the trigger and step out of active surveillance. So, you know, sometimes it's pressure from family members, and I see that a lot. So I think it really is an individual choice. I think it's something that you need to discuss with your urologist. If your urologist doesn't want to have a decent, detailed conversation with you, maybe you need another urologist. You know, you have to have communication with somebody who is treating you, beginning, middle, and end. Are there therapeutic benefits to prostate massage? No. The only reason to endure a prostate massage is in the event that somebody has prostatitis. And I think in some ways even that has kind of fallen out of favor, because there are better drugs now to treat prostatitis, which is infection of the prostate. So, you know, I think for some men, prostate massage is pleasurable. I guess that's therapeutic in a way, but you know, other than for treatment of prostatitis, no. Do you have any advice for the single man with prostate cancer who is still seeking an intimate partner, a woman, or shall be undergoing brachytherapy in 1 week's time? Sexual effects not yet known yet for me. Okay, so so let me just perhaps address the sexual side effects of brachytherapy. In all the studies that I have seen, brachytherapy tends to have the least sexual side effects, because the nerves that control, in part, erections. So an erection is a product of nerves and blood vessels. So the nerves that essentially control erections lie on the outside of the prostate. So I'm looking for something. I've got a little model in my office, and obviously I'm at home. So like, let's just imagine that my lip ice, even it's kind of a circle, is the prostate. The nerves run on the outside on both sides. And so external beam radiation, cyberknife, SBRT, whatever you want to call it, will fall into the radiation field with those forms of radiation. With brachytherapy, which is localized because the source of the radiation is within the prostate, you tend to see less sexual side effects. They tend to occur at 1 to 2, maybe 3 years after the treatment. But overall, less problems with brachytherapy than any of the other treatments. You know, so as a single man, this is concerning. It's interesting to me, and I actually find it rather inspiring, where I see, you know, a man in his 70s or 80s who is single, he's maybe widowed, or he's single by choice, or not by choice, and you know, he's interested in finding a partner. And what I will often hear is, if I can't have erections, nobody is interested in me. And one of the things that I will often talk about is that, you know, often women, not all women, but often women who would be attracted to a man in his 60s, 70s are postmenopausal themselves, and erections are not necessarily you know, the straw that would break the camel's back, so to speak. So, you know, I think, you know, it's important to be realistic about this and communicate. If you meet someone who strikes your fancy, I think it's important to be open and honest before you get into that whole emotional connection, right? And you're in love, not just in lust. You know, because it's really hurtful to be rejected just based on what your penis can or cannot do. So I would certainly, you know, advise open and honest communication, and being realistic that, you know, unless, you know, perhaps you're going for somebody in her 20s or 30s, which I would strongly not advise, as somebody in their 60s or 70s or 80s. You know, really, a lot of women, and honestly, I could actually start a dating service for men and women who have been through cancer treatment, because I hear from women, I just want to meet a man, you know, who, for companionship. Remember the days when we could like go to the movies and out to dinner, and I'm hoping those days come back soon. We're in total lockdown here. We've been in lockdown for 8 weeks. It's making me nuts. I haven't seen my grandchildren for 8 weeks. It's just awful. Anyway, so, you know, back in the days where people could date like in person, people want companionship, women want companionship, and I think men want companionship as well. Okay, I'm on active surveillance, and I'm wondering about the sexual side effects of simple prostatectomy versus radical prostatectomy. So I have never heard of anyone having a simple prostatectomy to treat prostate cancer. They always do a radical prostatectomy. So the difference is, with a radical prostatectomy, the entire prostate, the seminal vesicles, and the seminal vesicles are removed. With a simple prostatectomy, this is really what they do, essentially like with a Roto-Rooter, perhaps, but more extensive. So they kind of scoop out the tissue, leaving the capsule intact. We generally don't do that for the treatment of prostate cancer because you run the risk of leaving some cancer behind. So there we go. Somebody is asking about the impact of, sorry, I keep losing this, the impact of finasteride. So finasteride is a medication used to shrink the prostate. It is sometimes used in younger men to prevent hair loss. And finasteride has an impact on erectile functioning. And this is something that a lot of younger men don't know. And so there's actually something called the post-finasteride syndrome, where predominantly young men who've been on it to prevent hair loss, like head hair loss, land up with erectile dysfunction that may persist and doesn't, you know, they don't return, which as you can imagine, is quite devastating for someone in their early 20s or 30s. Okay, here's another question. Post prostatectomy or radiation, is there any pleasurable feelings at orgasm? Absolutely. So this is actually an interesting one. We don't particularly see changes in the sensation of orgasm with radiation. We will certainly see a decrease in the amount of ejaculate after radiation. The ejaculate tends to be decreased in volume, also much stickier, because the seminal vesicles, which contribute the fluid portion of your ejaculate, are in the radiation field. They're also treated, so there's less fluid. With radical prostatectomy, however, it's really interesting. What we see is there are some men whose orgasms feel the same way as they did before. There are some men whose orgasms are like a non-event. It's, you know, men say to me, it's like, you know, and then there are some men whose orgasms are so painful, so intense, that some men actually avoid sex and avoid orgasm because they're so painful. This often is because of the muscles of the pelvic floor. So most men who have radical prostatectomy should see a pelvic floor physiotherapist ahead of the surgery for an assessment of the pelvic floor. It's an internal examination, yay. Because if you have a tight pelvic floor to begin with, so if you're an athlete, if you do yoga or Pilates, if you're a ballet dancer, you've probably got a tight pelvic floor, and that'll perhaps lead to pain or sometimes actually incontinence even. If you have a lax pelvic floor, and we see this a lot in men who are overweight, your orgasms may feel like nothing on earth, and you'll probably land up also with some incontinence. So a pelvic floor physiotherapist can be your best friend. So really, you know, a lot of the sensation does come from contractions of the muscles of the pelvic floor. Next question. I'm sorry, I'm like zooming through them, but I'm acutely aware of the time. The drugs eliminated libido. Will it return once off drugs? Yeah, this is a really interesting one. For some men, yes. For many men, no. There's been an interesting study done recently that looked at the return of testosterone, which for men is absolutely involved in desire or libido. And the drugs that this it's a lady. The drugs that this lady is, or it might be a man using his partner's computer. The drugs that this person is talking about are the LHRH agonists or antagonists, the so-called hormone therapy. I don't like the term hormone therapy because I think it for some people implies that we're giving the man hormones. We're doing the exact opposite. So the correct term is androgen deprivation therapy. We are stopping the production of an androgen, testosterone, in your body. So there's been a recent study that looked at the return of testosterone levels to baseline or to within normal range. So, and what they found, I think, and I'm not really good at remembering statistics, but far fewer men returned to the normal range than men who returned to baseline. I think it was that. Don't quote me on it. So, you know, it depends on age, it depends on duration of androgen deprivation therapy. If you've been on it for 6 months, it's going to have less effect ongoing when your body's eliminated it than if you've been on it for 18 months or 20 months. Okay, let me keep going. There's a question from Rob that is also private, so I don't know if I should answer that. So if you want to, just make it unprivate. Next one, beyond psilocin and Viagra, any thoughts on Trimix or the peptide PT141? I know nothing about the peptide PT141. I am a huge fan of penile self-injection, and obviously it's very easy for me to talk because I don't have a penis. My husband does tell me that I have balls though, but I think he means something else. That was a joke, people. Thank you very much. Somebody liked my joke. You know, seriously, if you lose your sense of humor with this, you really are something. So I'm a huge fan of penile self-injection because it works. It works no matter what, no matter the length of time since treatment, no matter your age. It's just a matter of finding the right dose. It's really important to taught how to do it properly. What I find is a lot of men who are not educated on how to draw up the medication, how to give the medication, given really good instruction. Often those men find that it doesn't work because they're not using it properly. There are certainly videos on YouTube that show you what to do, but instruction is really, really important. What are your views on testosterone replacement therapy for men on AS? What about, whoops, sorry, I have to go back. What about after radical prostatectomy? This is a very, very, very controversial topic. Prostate cancer is an androgen-dependent cancer. It is dependent on testosterone in order to grow. So, you know, I personally, from the evidence that I have read, and some of you may know, there's a certain urologist who's a huge, huge proponent of supplemental testosterone. I don't think it's safe while on active surveillance because you are risking the cancer growing because it's fuel for the cancer. After radical prostatectomy, I think this is something that some men will do. They often have to sign a legal document to say that they fully understand the risks, so to prevent any liability on the part of the prescriber. So I think it's just something that you really, really, really need to think about. And you've got to be really careful about those ads you see on TV. There's an ex-football player. I see this early in the morning. I get up at about 4 and I watch CNN. It's not good for my health. And there's this ad for some testosterone supplement. I think it's from GNC. You text the number and they send you a free supply. You've got to be really, really careful of these supplements. Sometimes they're absolutely useless, but sometimes they actually do contain the active ingredient, and if you have prostate cancer, you should be really careful. Okay. Let me go back. I really don't want to answer personal questions, so I am going to skip over some of them that are particular to your particular circumstance, just for a whole host of reasons. Okay. So here's an interesting one. In my travels overseas, I visited prostate cancer organizations in London and Edinburgh. They seem to be much more proactive with sexual information than doctors in the US. Is there a reason for this? Observations and comments, please. You know, I don't know. Certainly, historically, the UK has actually not funded, they have a national health service, much like we do in Canada. And the UK has not funded PSA screening, and they tend to, men who are diagnosed with prostate cancer tend to have radiation more than radical prostatectomies. I think, I'm not sure the reason for that. I just think that it is absolutely negligent not to talk to men about the sexual side effects of all these treatments. I think the timing of the information is really important. We know that after someone hears the words, "You have cancer," they hear 10% of what they are told next. And what we tend to do is tell someone that they have cancer and then statistics, probabilities, all kinds of stuff, and you hear none of it. The healthcare provider goes, tick, I've talked about all of that. And then, nobody understands why this man says, "Oh, I was never told any of that. Why wasn't I warned?" Well, it was all about the timing and sometimes about the way that the information is presented. That's really important. We all learn differently. Some people are visual learners. I think that waiting a week or two after finding out that you have prostate cancer, the dust has settled a little bit. You get up every morning and you realize you're alive, that you haven't died overnight, fortunately. And and certainly that is my practice. I don't give men information on the day that they get their biopsy results. I see them a week or two later. Interesting question from Howard. Do medical doctors who care for men with prostate cancer ever take sexual histories? Yeah, pretty much not. How can men get help? You know, certainly organizations like UsToo, and I write a column for them called Between the Sheets, and I'm actually just working on some new questions and answers for them. You know, find information any way you can. Dr. Google can be somewhat helpful. You know, certainly look at places like the Mayo Clinic, Memorial Sloan Kettering, the American Cancer Society, ASCO, the American Society of Clinical Oncology, and the American Urological Society are legitimate sites. If the site is trying to sell you something, run for the hills. What treatments are available for sexual issues? How successful is it? So, you know, essentially we approach erectile problems in a staged approach, starting off with the oral agents that help maybe 40% of the time, huge amount of attrition. So often men will just take 1 or 2 doses of the medication. They're not instructed on how to take the medication. So, you know, I hear from men, well, you know, I took it and it didn't work. And I'll say, well, can you just tell me exactly how you took it? Well, after dinner, I took the pill and nothing happened. And my wife went off to play Marge or bridge or something. And I'll go, oh, okay, this is where we have to start. You got to discuss this with your partner if you want him or her to be involved. You have to wait about half an hour, depending on the medication that you've taken. There has to be genital stimulation, because all that these oral agents do is actually trap blood in the penis. It doesn't cause an erection. If that doesn't work, generally what you'll see is that the next step is the penile pump, which I am not a fan of. It's invasive, it's mechanical. You have to use a very tight constriction band, which hurts like stink. The penis feels cold. Often partners are not super excited about that. And there can be hinging where the constriction band is. It's also really quite difficult to use if you have a little bit of a tummy, because you've got to hold the base of the pump very, very tightly against the pubic bone and to make that seal. The next step is penile self-injection. There's also a little pellet, an intraurethral pellet, which contains alprostadil, which is inserted into the urethra. Super, super expensive, and it stings like crazy. And pain with sex is something that like this much of the population enjoys. So I'm not a huge fan, and it's also so expensive. It doesn't need to be. It's been around for decades, and I really think that these drug companies need to stop gouging people. And then finally, these penile self-injections. So there's Trimix, there's Bimix. You can actually get these with a prescription online or from a compounding pharmacy where you live. Hugely effective, but once again, you've got to know how to use it. And then finally, there's the penile implant, which is surgery. It is expensive, lasts about 10 years, but generally men are quite satisfied with the penile implant. However, I have seen some men here experience problems like mechanical problems with it and pain, because it's actually implanted into the penis. Okay, I'm trying to move through these questions because there are lots of fantastic questions. Thank you so much. I was really scared that nobody would ask questions and I would just have to like make things up. Overall, are sexual side effects worse for radical prostatectomy or external beam radiation? And I mean, I think this is really an individual thing. The difference is that with radical prostatectomy, there is immediate, profound loss of erection, which may improve over 1 to 2 years. May improve. Depends on age, depends on preoperative erectile functioning. If you go into surgery with not great erections, this is not going to fix that problem. It's only going to make it worse. It depends a little bit in terms of how much damage is done internally. Everyone talks about nerve sparing surgery. Doesn't seem to make a huge amount of difference. With radiation, it tends to be a more natural lessening of, rigidity or maintenance over time. And honestly, a lot of my patients, they're 3 or 4 years after radiation, and they come and see me, and I say to them, what do you think is the cause of these changes? And they say, well, I'm 3 or 4 years older. And I say, do you think it has anything to do with the radiation? Oh, so, it does tend to be, it sort of mimics aging more. Here we go. Howard. Sorry, I just missed you. Are there any exercise? Sorry. I just want, this thing's going fast and I can't see it. Okay. Are there exercises men can do to preserve sexual function? Not that I know of. And if I did know of it, I would patent it, I must tell you, because I'd make a whole bunch of dough. But it's a good question. I think overall good health is really important. Remember that the penis is the canary in the coal mine for cardiovascular health, so that we know that men who in their 40s and 50s who are otherwise healthy, if they start experiencing erectile dysfunction, so this is outside of the context of treatment for prostate cancer, but if an otherwise healthy man starts to experience erectile changes, he doesn't need a prescription for Viagra, he needs a cardiac workup, because the arterioles supplying the penis are so much smaller than the arteries in the rest of his body that changes to the lining, to the endothelial lining of those arteries, which is the hallmark of cardiovascular disease, happen down there sooner than you see it somewhere else. Okay, what role does nutrition play in sexuality? Holy smokes, Howard, you got lots of questions. I'm going to get to some other people's questions if you don't mind, but this is an interesting one. What role does nutrition play in sexuality? Are there supplements or food that can help? No. But a healthy diet, once again, a heart healthy diet is a prostate healthy diet. A lot of these supplements have been debunked. There's just been a large Cochrane review. So the Cochrane organization does these massive reviews of, all kinds of things. And they just did a massive review of multivitamins. Not worth the money. If you eat a good diet, you don't need multivitamins. And every night on the news and during programming, I see so many ads for this one and that one, and this for men and this for women. Really, for most of them, you just get expensive urine, and some of them actually you have to be really careful, particularly for the vitamins that are fat soluble. Okay, there's another private one. Howard, I'm just going to skip over you for the moment. How can men, as you say, mourn loss of their sexual lives? That's a really interesting question. I think that part of it is just recognition that what was and what is. Certainly involving your partner, if you have one, in terms of actually talking about it. Some people will actually write a letter to their penis. Expressing and people often go, oh, that's just so woo-woo. But writing a letter or journaling about it really does help you to think about it and to get your thoughts out and to really address, what is important, and to actually perhaps thank your penis for years and years of pleasure and function, and also remember that it's not just about your genitals. A lot of it's about your heart. And I pointed to my head. A lot of it's about your head and your heart. And it's really important, if you are part of a couple, to go through this as a couple. Okay, what about marijuana and sex? I'm not sure what I'm supposed, I don't know what about marijuana and sex. Certainly for some people, it can be an enhancement. For other people, they just eat a whole bunch of brownies and then go to sleep. I particularly don't like smoking or vaping because it's putting a bunch of carcinogens and stuff in your lungs that just really shouldn't be there. you know, but certainly eating gummies, or I mean, now you can get like soda and infused. So, you know, if that floats your boat and it's legal, go for it. Are there negative side effects with the cystoscopy? Yeah, there are negative side effects with cystoscopy, you know, beyond, you know, bleeding, certainly irritating the urethra and irritating the sphincter, which closes the bladder. And certainly I think, you know, there's a huge mental part of, you know, really having this rather large scope inserted into your urethra, which is not particularly fun. So I actually see a lot of men who see erectile changes after cystoscopy, and it's not anything physical. It really is mental, because it's, you know, quite unpleasant. Here we go. What is the realistic percentage of men who return to baseline sexual function after radical prostatectomy? Should this be disclosed to men prior to treatment? Yes, it should be disclosed. The range of men who return to baseline erectile functioning is between 10 to 60%, depending on how the question is asked in the study. So a lot of these studies are flawed because there's, you know, there's bias in terms of the way that this is measured. So, you know, the definition of erectile dysfunction, or the definition of erectile function, is the ability to achieve and maintain an erection for the purpose that it is intended. So you know, a lot of these, this is why you see this wide range, right? There's some studies that say, you know, only 10% of men return to baseline, and there are other studies that say that, you know, 40 to 50% of men return to baseline. Is not good. Okay, Howard, gotcha. And yes, absolutely, men should be told about them. And I don't understand the reason why men are not told, because I actually think that it can, there's potential for legal liability there. And, you know, sometimes I think that it's difficult for urologists to talk about this, because I think sometimes they think that if they told the whole truth and nothing but the truth, men would run for the hills. And I think that really is a huge discredit to men, and certainly to their partner. And, you know, most partners would say, I'd rather have you with no erections than not have you. So it should absolutely be disclosed. What about laser ablation? They claim you will maintain sexual function. So this is, you know, generally laser ablation is used for benign prostatic hypertrophy. It's generally not used for prostate cancer. Depending on the skill of the operator, so the person operating the laser, them and the depth that they go to, how close they get to the prostate capsule. Remember, those nerves are just on the outside, and the nerves are extremely sensitive to heat and to tension, you know, pulling. So that plays a role. Does omega-3 help with sexual function? You know, the evidence here is not really strong. One of the problems with supplements is that the studies have never been done because there isn't much money to be made. And studies, particularly in the realm of prostate cancer, because men tend to live with it and die from something else. So studies about these kinds of things need to go on for many, many, 20, 30 years, and you get a lot of attrition, right? So men, you know, forget to answer the questionnaires, or they just get annoyed with having to answer the questionnaires. So studies in prostate cancer need to be really, really big, which makes it really, really expensive. And there's not that much money to be made from omega-3. You know, it's freely available. It's not patented, so we just don't know. Sorry, Howard, I didn't mean to annoy or offend you. Okay, you indicated that with radiation therapy, sexual function may decline over time. Are there any negative effects of radiation therapy that are more pronounced, either short-term or long-term? Yeah, absolutely. So what like to explain side effects of radiation as internal sunburn. So, you know that if you stay out in the sun and you're not wearing sunscreen, you're going to get a sunburn. And, you know, when you go to wash your hands, when you've got a sunburn, it kind of stings. So think about internal sunburn. So the bladder gets irritated. So what may happen is that you need to go more often, more frequently, so you need to urinate more. You have this urgency and frequency, and maybe you produce a few drops, but it really feels like you've got a full bladder. Does improve with time, and we actually have medication to help calm the bladder, which is a muscle, it's not a balloon. And certainly some people will have some bowel issues. So perhaps, you know, once again, frequency, perhaps some diarrhea does tend to get better because the body heals itself. So with time, that does tend to get better. If somebody has bad proctitis, which is irritation of the rectum, we have lotions and foams and that kind of stuff that can really help, but it does get better. Okay, what are the alternatives to biopsy? Can MRI be used in place of biopsy? Generally, these sort of alternatives to biopsies are used after the initial diagnosis, which does need to be made with a tissue diagnosis. So you certainly need a biopsy for the initial diagnosis. And then some of these other technologies can be used to kind of monitor things. And the aim of that is really to avoid excessive biopsies. And it's really quite different in different parts of the country. Certainly some big academic centers will have a lot of sort of high-tech stuff. If you're living in a smaller city or smaller town, or in Canada, where we tend not to have a lot of these technologies, things tend to come to Canada slower than the US for a whole variety of reasons. Okay. How does aging impact sexual function? Do men blame prostatectomies when aging may be the reason for declining libido and erectile dysfunction? We certainly see reactive loss of libido in men who have erectile dysfunction. So what do I mean by that? The kind of loss of libido that you see for men, you see in men with androgen deprivation, is different. The cause is different in men who are not on androgen deprivation therapy, but they are unable to have erections because, you know, the thinking is, well, if I can't do anything, why on earth would I be desirous or libidinous or want to have sex? So that's a reactive loss of libido. So, I mean, men blame all kinds of things for problems. You know, they blame their partner often for their erectile or other sexual difficulties. You know, aging happens. As I mentioned previously, erections are a function of blood vessels and nerves. And particularly with blood vessels, as you get older, your arteries are more rigid. It's not the only thing that's more rigid. Your arteries are more rigid. The endothelial lining has changed. And so there is diminished blood flow, and that contributes to loss of erections or loss of the ability to maintain an erection. So you can get an erection, but you lose it really quickly. A lot of that also can be mental because men are so anxious. Oh, you know, whoa, it's up. I got to use it, and then they lose their erection. Is MRI? Oops, I just heard myself. Somebody needs to turn off their mic. Is MRI guided biopsy better than truss biopsy? So a MRI guided biopsy, so it's, you know, that's just a matter of what they can see. With a transrectal ultrasound biopsy, that's what truss stands for. They don't see a lot of detail. You know, the prostate doesn't give up its secrets very easily. The imaging from an MRI is much better, but the actual biopsy remains the same, right? It's just that they are better able to visualize what they are doing. And MRI guided biopsies are not available widely for everybody. Once again, if you live in a smaller town, or perhaps you're seeing a private urologist who, you know, doesn't want to invest in these really expensive technologies, it might not be available for you. Before undergoing a radical prostatectomy, should men undergo a sexual exam evaluation? I'm not sure a sexual examination is going to tell anybody anything, and I think it's kind of invasive, but certainly a sexual evaluation or information session, I think, is really important, so that the man is realistic about what might happen after, and has the opportunity to ask questions. And really the involvement of the partner is also really, really important, because 4 ears are always better than 2. Speaking of blood flow, any thoughts of Gaines wave or similar therapies? I do not know what Gaines wave is. Oh, shockwave therapies. Oh, this is an interesting one. There's been a lot of research done recently on shockwave therapy, and there is not sufficient evidence in the context of erectile dysfunction, period, never mind in the context of treatment for prostate cancer. So the FDA does, basically says that it is way too early. We do not have enough evidence to, recommend or encourage shockwave therapy, electroshockwave therapy for the treatment of erectile function. I think that might come in the next couple of years, because urologists have sort of jumped on the bandwagon with this one. So this is really to be determined. What advice do you have for partners, spouses, when men go on active surveillance? Likewise, advice for partners of men who are undergoing more aggressive treatments. Communication. You've got to talk about this, because we make assumptions about what our partner is thinking and feeling, and I do it, and my husband absolutely does it, and I think we get it wrong about 90% of the time. So you've got to talk openly and honestly about it. And this is a topic, particularly sex, is a topic that's really hard. I try not to say hard. It is really difficult to talk about because it's sensitive and it's emotion laden, and we protect our partner's feelings, and we want our feelings protected. And most of us communicate about sex with grunts and squeaks, as if we were dolphins or whales. And that works for dolphins and whales. It really doesn't work when you have a problem. So you've got to use words, and you've got to talk in I statements. I think perhaps one of the most important things for a partner when a man is on active surveillance is not to pressure him to have some form of treatment, to be really respectful of his decision. And that's once again another reason why it's so important for spouses or partners to go to all appointments. And I certainly know sometimes I find a spouse sitting in the waiting room, and I'll say, like, where's your partner? Well, he's in there. Well, why aren't you in there? Right? You shouldn't be in there when he's actually having a digital rectal exam, but you need to be in there for any kind of discussion. And likewise for men who are undergoing more aggressive treatments. I see many couples where the man is on androgen deprivation therapy. He has zero libido, so he stops touching his partner, like as in hand holding, or kissing her good morning or good night, or when he leaves the house. And these women automatically think two things. It's my fault. He doesn't love me anymore because I'm, I haven't had my hair done, because I'm not allowed to go to the hairdresser because of COVID, or he's got someone on the side. I can't tell you how many times I've heard that, and nothing could be further from the truth. He has just completely lost any sense of that need to touch his partner and himself be touched. And I don't even mean in a sexual way. So, that is a huge issue for couples where androgen deprivation is at play, and you've got to talk about it. Women, or partners for that matter, might have to say, I need a hug, right? Because it doesn't enter the man's brain to do that anymore. Sorry. Oh, here we go. How many radical prostatectomies should a surgeon have performed to be regarded as proficient? How many radiation therapy should a surgeon have performed to be considered proficient? Surgeons should not be doing radiation therapy. It's a completely different specialty. So if your surgeon says, I'm going to give you radiation therapy, run. It's like the difference between a dentist and a chiropractor. Completely different skill set. This is a really interesting question. I don't know if, there's a certain number that the surgeon would be considered proficient, but I can tell you, if the urologist or surgeon is like doing maybe one a month, not a good idea, right? You need a high volume surgeon, but by the same token, somebody can be a bad surgeon and do a lot of surgeries. So if possible, go to an academic center associated with a university, because generally there are more checks and balances. There's a certain, level of ongoing education, collegiality, working in teams than solo practitioners. Are there any effective treatments for anorgasmia or poor quality orgasms? Absolutely, and it's a simple answer: a handy dandy vibrator. So most men don't know that you can use a vibrator. They think it's only for women. So a vibrator anywhere on the genitals, you've just got to do a little bit of homework and figuring out what works for you. But generally what happens is that the sensation from the vibrator is generally way more powerful than you can provide for yourself. And it also helps to kind of override the negative messages in your brain, the performance anxiety in your brain. So I think that that's a really good idea. I also think that you've got to look at what medications you're on. If you're not having any orgasms at all and you're on an antidepressant, that is probably the reason why you're not having orgasms, because antidepressants are known to cause anorgasmia. So that's something that you need to talk to your primary care provider about. What are my thoughts on brachytherapy for prostate cancer? If you're eligible and this is something that you like, talk to one or more radiation oncologists who do brachytherapy and who do a lot of cases. It's an effective, minimally invasive treatment for prostate cancer that is as effective as other forms of radiation, as effective as radical prostatectomy, but you have to be eligible for it. In your experience, are women or men more involved, engaged in therapy? How do you motivate men and women to talk to you about things they won't even talk to each other about? Oh, that's a really great question. So a couple things here. There is something that happens when a couple is in the room with an objective trained professional who knows what he or she is doing, that changes the communication between, or the lack of communication between the members of that couple. So sometimes I will see a couple, they're kind of shy, they're shifting in their chair. I start gently asking some probing questions, and 98% of the time, that couple turn towards each other and start talking, and I'm sitting at my desk thinking, would it be rude if I checked my email? Yes. Could I go get a cup of coffee from Starbucks? No. So it's, the professional is there to keep a rein on emotions, to gently ask probing questions, to not let people off the hook, but in a kind way. And so, I think it all depends. Often I will see both men and women who come to see me alone because they want to check me out, because they don't really understand what this is about. I've had people ask me if they have to get naked in front of me. Good grief, no. If they have to have sex in front of me, hard no on that one. It's about talking. It's about communication. It's about me gently guiding the conversation and getting people to fess up. Not to their deep, dark secrets, but about what they're actually feeling. So when people do come alone, one of my first questions is, are you a part of a couple? If they say yes, I say, I will see you this one time alone, but this is not a problem that you are going to fix by yourself. And I hear this often, men like to fix things, right? So men come and say, well, this is my problem, I'm going to fix it. My wife doesn't need to know anything about it. What? No. Absolutely not. So I'm really quite committed to that. You will only solve a problem with your partner. How does the therapy you offer work? I don't know. It just does. Listen, sometimes it doesn't. I'll see a couple once or twice and then they don't come back because they don't like me. They don't actually want to address the issues. Maybe one of them does and the other one doesn't. They don't like me, they don't like my style, which is fine. I practice brief resolution focus therapy. I'm really not that interested in how you were toilet trained when you were 2, 3, 4, or 5. I don't really want to know if you wet the bed when you were a kid. I want to give you the tools to move forward and find some resolution. And for some people, it's, you know, I don't want to do that. I don't want to do that. So thank you very much, Dr. Katz, and off they go. They may come back 6 months later. So, you know, how does it work? People solve their problems. I'm just there to facilitate it. Really, I don't think it's magic at all. What special training do therapists like you undergo? Do urologists or family doctors undergo? No. So it's actually surprising that in medical school, there's generally around 2 to 3 hours in the whole of medical school on sexual dysfunction, and the focus really is on erectile dysfunction. So most urologists, you know, who just are urologists, they're surgeons. So they don't really have much training, certainly in sort of the counseling therapy aspects of it. Their focus is on getting rid of the cancer. I have gone through a general sex therapy training at the University of Guelph. And honestly, a lot of this is kind of self-taught. I am credentialed by the American Association of Sex Editors, Counselors, and Therapists. So that's my certification. As a registered nurse, I have an understanding of the anatomical and physiological issues that affect sexuality, and particularly in the realm of oncology, which often sort of what I call common garden sex therapists, and I don't mean that in a horrible way, just don't have, because they don't come from a nursing background. So in many ways, I have sort of a unique skill set that I'm really proud of, and I'm constantly learning. I learn from my patients, I learn from the papers that I read. I've got a giant pile of papers there that I was looking at around active surveillance and found very, very little. Yeah, so what training do physicians have on sexuality? Unfortunately, very little, but there certainly are. I have colleagues in the US who are actively working with medical schools to get more training around human sexuality into the medical school curriculum. Yeah, so if anybody really wants to see me for counseling, Howard has my email. Because of jurisdictional issues, I am not licensed in the United States. I have to have you sign a disclaimer that you will not sue me as protection for myself. So, you know, really what's involved is I would see you over Zoom, and I obviously I charge $200 an hour. And which you can claim on your insurance if you want, but I don't do insurance claims. And I'm happy to see anybody that feels that I might be helpful to them. So it's my email address is counseling@drankatz.com. So it's counseling with 2 L's. I often make a mistake and only put in 1 L. It's Ann with an E. And you can there's actually a link on my website, which is just drankatz.com. Aside from doing lots more than one radical prostatectomy per month, are there any resources to help to determine good surgeons versus all available surgeons? You know, certainly ask around. Look at ratemymd.com, because what you will often find there, I mean, you get 2 kinds of people who actually go and rate their physician on that website. You find people who are super satisfied. You find people who are really, really, really unsatisfied. You know, what I would do is I would go and see somebody and just kind of, you know, evaluate them. Are they eager to talk to you? Do they answer all your questions? Go with a written list of questions, because you know what happens when you get in the room, right? You feel pressured and all thought goes out of your brain. You know, before anybody lays hands on you, you know, look at their offices. Super fancy offices don't necessarily mean that practitioner is super good. You know, sometimes that's just like frosting on the cake. But certainly if things look unkempt, you know, like the chairs have got whole rips in them. Certainly now with COVID, you know, you want to make sure that there is what in the US you call social distancing. Here in Canada, we call it physical distancing, because social distancing feels like a social disconnect. So, we're politically correct here. So, make sure that there's hand sanitizer. When the person walks into the room, they need to wash their hands, whether they're going to touch you or not. They also need to wash their hands when they leave the room. I mean, these are all kind of just indicators of the kind of care you might receive. I've heard of a nurse practitioner who offers sexual counseling, including handling the penis, stretching it, etc. Is that normal for nurse practitioners? No. No. The only time that I have to look at a penis is when I am doing the teaching and the test dose for the penile self-injection. And I actually don't touch it at all. Yeah, no, I don't know what is the point of stretching? Just hard no there. Yeah, I don't know. That just seems a bit weird to me and quite frankly, makes me a little bit uncomfortable. What was the website you just recommended for Rating MD? It's called ratemymd.com, I think. Yeah, ratemymd.com. Yeah. Oh gosh. Whoa, we've gone like half an hour over. Any other questions?
Well, it looked like we got a very good series of questions, so I'm very pleased, and obviously the audience got a lot out of it as well. So those people who asked me a private question, if you want to, because I'm kind of fading fast, email me your question at counselling@drankatz.com and I'll answer it that way. Okay.
Okay.
Howard, over to you.
Sorry?
No, I was passing it back to Howard. That's all.
Am I live?
You're
I'm
on.
muted.
You're on.
Okay. Well, Anne, I don't know if you can hear the thunderous applause, but thank you. We really appreciated your coming out on such a strange night. Congratulations on drawing the biggest audience we've had at a weekly meeting.
That's great.
Yeah, we got up to 55, so that was pretty good.
Yeah.
Actually, I saw Joe as high as 61, Joe.
Did you? Okay, I missed that.
Yeah. So, but at any rate, you have our thanks. I hope maybe someday in the future we can have you back, give a new audience a chance, maybe some new questions. But
sure.
Otherwise, thanks. I don't know.
I share my thanks as well. We did really well.
Thanks, Joe. And good evening, everybody. Keep safe, keep sane. If you have the opportunity to get the COVID vaccine, run, don't walk.
Yes, we will be posting your contact information on our website as well.
Great. Thank you very much.
Thank
Good night,
you.
everybody. Bye.
Thanks,
Bye-bye.
everyone. Have a good night. The AS team want to hang around for a minute?
Sure.